Hello, everybody, and good morning. Thank you for taking the time to join us early on a Monday morning. I hope the sun is shining wherever you are. My name is Tamsin Rose, and I have the great pleasure to be your moderator today for the event organized by Digestive Cancers Europe. And the title is Together Driving Change and Saving Lives. And we're going to be focusing on the issue of colorectal cancer screening. We're going to explore together what works, where there are gaps, and what we can do together to create momentum for change. For that, because change is the goal of today. We want to improve the situation because clearly screening saves lives. So let me just introduce a few housekeeping elements. The first thing, of course, I'm sure you're all used to the online platforms, but please, everyone needs to be on mute with your cameras switched off, except for the speakers and panelists. This meeting is being recorded and it will be made available for you later on the website of Digestive Cancers Europe. So you'll have a chance to watch again and see more details of what was being done. And of course, that means that the PowerPoints that are used will also be available to you. Let me just show you the screen here, what you're very familiar with probably by now after many months of being in the online environment. In the bottom left, you've got the option to unmute yourself and switch on your camera. And we ask that you only do that when called upon if I ask you to intervene. How we most want you to engage with us is using the chat function. So please feel free to engage with us, respond to the speakers, and speakers, they're speaking from their office or their home, and they have no way of seeing you, the audience, and understanding whether what they're saying makes sense to you. So please give your reactions to the speakers, but use the chat function, which you'll see on the bottom of the menu. You don't need to wait until I tell you it's the time for questions. At any time during the day, please give us your reactions. We will be monitoring the chat and I will be bringing that into the conversation with our panelists. So when we get to the time of each session where there is a moment for an opportunity to engage, here's how you do it. Please raise your hand and you can see here on the screen how you do it. And this lets us know that you want to say something. Already, if we've seen your messages in the chat, we understand that you've got something to say, but if you want to physically say something, please raise your hand. And that's so that we don't interrupt each other. And as a reminder, please keep your camera off and muted unless you're one of the speakers until the moment when we have the Q&A and I have an opportunity to bring people in. If you've raised your hand, I will know who wants to speak. Those were all of the different housekeeping messages I wanted to say. We're going to have a fantastic day today. We have some very, very good speakers, some really useful PowerPoints. They will all be made available to you. So let me now hand over to our host of today's event. And here you can see the social media hashtag if you'd like to use Twitter, which is CRC Screening. And this is what we'd like you to use. First, I'd now like to hand over to Dora Konstantinidis, who is the chair of Digestive Cancers Europe and associate of PASICAF from Cyprus. Dora, introduce us the summit, please.
Right. Can you hear me now?
Yes, we can hear you.
Okay, thank you very much, dear Tamsin, for the very useful, very succinct introduction. And I would like to thank everybody for being here with us today. So welcome to what, as Tamsin already mentioned, is going to be a very interesting day with highlights on the best practices, etc. Because we do want to bring change. So it is important that you are here with us, supporting us and sharing a common vision to save lives and reduce the digestive cancer burden, especially for colorectal cancer, which is one of the most preventable and curable when diagnosed early. So that's where our commitment lies. So we would like to thank all of you, our partners, our supporters, and especially Stella Kyriakidis, our European Commissioner on Health and Safety. So we can start by introducing DICE. So thank you very much, Ghislaine, for the presentation, taking it forward. So just a few words about DICE, Digestive Cancers Europe, starting from Europa Colon. And here I would like to thank our founders, which are Yola Gorbooth, Eric Van Kutsem, and Stefan Gisels. So we're here today representing 32 associations throughout Europe. And at the European level, we represent all the patient community which is diagnosed with cancer of the esophagus, the stomach, the pancreas, the colon, the rectum, the liver, and other more rare digestive cancers. We represent the 900,000 people who get a diagnosis of digestive cancer every year in Europe, as well as the 1.5 million digestive cancer survivors. We represent the families as well of the 600,000 patients who die every year from digestive cancers. So you can see the numbers are large, and this is what we aim to change, to bring about a reduction in all of these numbers, and we can do it together. Just having a look at the different cancers and how they relate. So we can see that the new number of cases for esophagus are nearly 53,000 new cases every year, and 45,000 people die of esophagus. Similarly, for the stomach, we can see that there are 133 new cases with corresponding number of deaths of 102,000 people losing their lives from stomach cancer. And coming on to colon cancer, which is our subject matter for today, you can see the numbers are huge. 312,495 people are diagnosed every year, with 157,000 people dying of colon cancer. And adjacent with that, we have 175,219 people diagnosed with the rectum cancer and 81,000 dying from that. Now, as you can see, this is where we can make the greatest change. It is feasible. That's why we need to move forward. For pancreatic cancer, as you can see, things are not as good because we do have high numbers, both of new cases, and at the same time, the percentage of mortality is at a very high stage. So that's another subject matter for another time, but it is of great concern. And liver cancer, we can see we have 86,000 new cases every year, 80,100 people dying from liver cancer. And here is where we are very happy to say that we have a new partner in our effort to combat liver cancer with the ELPA Association. So a lot of work to do, but we can focus on the doables, and the doable is colorectal cancer, starting off with, because of the great numbers, because of the possibility of bringing about the change through screening, as we will see later on. As DICE, one might say, why do you bother with screening or prevention and all these? Well, our core value is based on patient care and being next to the patient and the carers and the patient community at large. So our members are our organizations who are next to the patient and their families, but at the same time, we want to make things better. We don't want to see these numbers of incidence and mortality taking place. So our actions go further and beyond, from the prevention stage right through to the whole patient pathway right through to rehabilitation and support at the end of life. So
Dora, I'm sorry, this is Tamsin. I'm just aware that we started a few minutes late. Could I ask you to, yes, to move swiftly through your
sorry.
presentation?
Okay,
Thank you.
okay.
Apologies.
Thank you. Yes, okay. So as an umbrella organization of cancer patients, colorectal, digestive cancer patients, we are eager to proceed with the European Union recommendations. And these were that in 2003, all ministers of health were committed to having population-based colorectal cancer screening programs for all citizens from age 50 to 74. And these guidelines specify that the desired colorectal cancer screening participation rate is higher than 65% of the target population. And we're still very far from that objective. So looking at this European map, we can see that this target has only been achieved in one country, and we can see that Slovenia needs to share with the rest of us how they managed to achieve this target. I'd like to just mention that Cyprus, in the pilot CRC screening population program, had the figures of that out of the 30% response rate that we've had in our 50 to 69 target group, 10% were tested positive, and out of this percentage, 84% of the people proceeded and had a colonoscopy. Unfortunately, a lot of countries have no data, so this is what we need to get on the ground, because without data, we cannot plan ahead and aim to make the difference. So that's why it is important to share good practices, to show for everybody to see the way to move forward. We would like to thank our event partners, and especially the European Commission, the International Agency for Research on Cancer, EUREGA, the European Regional and Local Health Authorities, and the World Endoscopy Organization. Similarly, this event would not have been possible without the support of our sponsors, and we would like, with this opportunity, to thank Johnson & Johnson, Aiken Chemical Company Limited, Olympus, AstraZeneca, Norgine, and Servier. So before I finish, I would like to just say a very warm welcome and a huge thank you to our supporters, everyone who's here today, and especially to our member organizations and our partners. And with this, I would like to proceed with the televised message from Stella Kyriakidis, our European Commissioner for Health and Food Safety, a dear friend.
Thank you. Thank you, everybody. And we're about to show the video, and just to say that we know we have more participants who've had some difficulties joining this morning, but we're trying to fix that for them. But in the meantime, let's watch the video from the European Commissioner for Health, Mrs. Stella Kyriakidis.
Ladies and gentlemen, friends, it is a great pleasure to join you at today's summit on colorectal cancer screening. I am delighted this conference begins with a call to arms to come together and drive change to save lives lost to cancer. Colorectal cancer claims too many lives in Europe. It is the second most common cause of cancer deaths in men and the third in women. Tragically, many of these could have been prevented by implementing best practices in screening to enable early diagnosis and treatment. European Council recommendations in this area date back to 2003. They called for all member states to implement population-based screening programs for colorectal cancer for all citizens aged 50 to 70 years. The target was a 65% participation rate for this high-risk population group. In 2010, new European quality assurance guidelines further underlined the importance of raising and maintaining standards in colorectal cancer screening across Europe. But targets do, unfortunately, not always translate into action. 17 years later, it is clear we still have a long way to go. Today, only 3 member states have population-based colorectal screening programs in place for 50 to 74-year-olds. And uptake is far lower than for breast and cervical cancer screening programs. There are also significant differences in access to screening programs between and within EU countries. One of the key objectives of Europe's Beating Cancer Plan is to fill these gaps and find new ways to improve cancer treatment and care, including population-based screening. This will require a strong commitment from member states to implement the necessary infrastructure and have the necessary trained staff to carry out the screening. But it does save money, and it definitely saves lives, and it prevents suffering further down the line. Europe's Beating Cancer Plan has to be a plan for all of us. Member states, the EU, all institutions and stakeholders. It will take a holistic approach with action at each stage of the disease pathway, prevention and early diagnosis, treatment and quality of life for cancer patients and survivors. It is built on the principles of partnerships, supporting member states to implement national cancer control plans, working closely with civil society and stakeholders, tying in with Horizon Europe Research Mission on Cancer. What we have learned over the last few months, and I see echoed in many of your patient stories, are multiple challenges in this area. A lack of information, fear of the procedure or outcome, financial and logistical concerns about treatment. These issues have also been raised in the thematic network on colorectal cancer screening that you have been organized by Digestive Cancers Europe through the EU Health Policy Platform. Our Beating Cancer Plan must address these concerns and ensure citizens have equal access to high quality screening programs, to rapid diagnosis, to effective treatment, and appropriate care and support. This is not about just increasing survival. It's about helping those who have cancer or have been through cancer to live the best quality of life possible. I look forward to working with Digestive Cancers Europe and all of you to make Europe's Beating Cancer Plan a success.
Thank you very much for that very clearly strong message of support from Commissioner Kyriakides, who has made it a core focus of her mission and her mandate in Brussels to raise the quality of care for cancer and cancer patient victims in Europe. Let me now pass the floor to our next speaker, who's going to explain to us exactly why colorectal cancer screening is so important. He's going to highlight for us where we are in the current landscape and some of the challenges to achieve those high targets that Mrs. Kyriakides outlined. And I'm delighted to introduce Dr. Partha Basu from the World Health Organization, the International Agency for Research on Cancer, IARC. Dr. Basu, the floor is yours. If you could let us know, you're on mute still, and you need to let us know when we need to change the slides for you.
Thank you so much, Jasmine. Okay, so, all right, you have the slides, so I guess I don't have to share it. A very good morning to all of you. And at the outset, I must thank the Digestive Cancers Europe for giving me the opportunity to speak at this forum. Let me start with a happy note. Can I have the next slide, please? Yeah. Next, yeah. Almost all across Europe, we see that the colorectal cancer mortality is decreasing. So this graph, what you are looking at, is showing that annual percentage change in the mortality rates from colorectal cancer in different European countries. And if the graph is jutting to the left, that means that the mortality is reducing. If it is jutting towards the right, that means that the mortality, unfortunately, is increasing in those countries. And you can very well understand that excepting few countries like Portugal or Croatia, almost all countries are showing an annual reduction up to 4% in the colorectal cancer mortality. But then it will be naive to think that this entire reduction is due to cancer screening only. It is essentially due to three reasons. Number one, there is definitely a change in the risk factors. Number two, there has been considerable improvement in the management of colorectal cancer. And number three, of course, is introduction and implementation of population-based organized colorectal cancer screening. Next slide, please. So let us see how colorectal cancer screening impacts incidence and mortality from colorectal cancer. I'm taking the example of United States of America that started introducing colonoscopy-based screening starting at the beginning of this millennium. As you can see on the left-hand side, there has been a steady decline in mortality over many years in the United States, essentially showing the improved management of the colorectal cancer. But what is very striking is the sharp decline in colorectal cancer incidence in both males as well as in females. And to say that this decline is largely because of colorectal cancer screening, we can look at the increased prevalence of colonoscopy-based screening in the country. On the right-hand side, you can see as the proportion of the eligible population getting more and more screened with colonoscopy, the incidence comes down drastically. Next one, please. Across Europe, we still do not have that much of information on how the screening is impacting the mortality rate. Then we do have studies that have looked into, in a very unbiased manner, what is the effect of flexible sigmoidoscopy screening on colorectal cancer mortality. And these studies, without bias, they have found that flexible sigmoidoscopy can reduce the colorectal cancer mortality between 21% to 30%. There is much less evidence on the effectiveness of fecal immunochemical tests, which is at the present moment the most commonly used test, as well as we are still waiting for more evidence on the effectiveness of colonoscopy screening in reducing mortality. Next slide, please. While we wait for that kind of data, we have real programmatic data coming from this report that we put together in 2017. This second European screening report is a huge exercise that not only projected the status of implementation of cervical, breast, and colorectal cancer screening, but also estimated the performance of these programs using a set of harmonized process and outcome indicators. So these indicators and then the outcomes, they are comparable. Next slide, please. So the very first report was drafted in the year 2007 by the International Agency for Research on Cancer in collaboration with CPO Piemonte in Italy and Finnish Cancer Registry. In 2007, we demonstrated that only 12 member states had population-based screening program, colorectal cancer screening program, and none of them had completed rollout across the country. When we say rollout completed, that means that at least 90% of the target age group should be invited to screening. Next slide, please. And in 10 years, we can see the substantial change that has happened across Europe. Now, we have population-based screening in 20 member states, with more than 70% EU residents between 50 to 69 years of age having access to population-based colorectal cancer screening, and 11 member states, they have already completed rollout across the country. Next one, please. This slide is very interesting. On the left-hand side, what you see is that the different screening tests that have been adopted by these population-based screening programs with, that was the time, when most of the countries were changing from GFOBT to FIT-based screening. So you can see still at that point of time, say for example, in United Kingdom, GFOBT was still being practiced, but then they're gradually changing. We can see the colonoscopy-based screening was being practiced in Germany, Poland, Czechoslovakia, and flexible sigmoidoscopy was being practiced in England and part of Italy. On the right-hand side, what we see is the screening coverage. Screening coverage is proportion of target population being screened in a particular year. And here you can see that none of these countries the member states have achieved the desired level of 70% or 65% of coverage. And many of the member states, they are well below the desired coverage. So we still have a long way to go. Next, please. This is, again, from a real programmatic setting, gives us a wealth of information in terms of how good is fecal immunochemical tests. So these are the slides that are showing the detection rate of advanced adenoma, detection rate of colorectal cancers, and screen positivity of FIT test compared to GFOBT test in the real programmatic settings. So the continuous lines are essentially for FIT testing. The broken dotted lines are for GFOBT. So if you look at the graph on the left, extreme left, that is very clearly showing that FIT-based based screening will be detecting a large number of advanced adenoma, many more than what GFOBT screening can do, irrespective of whether the screening is the first round of screening or it is a subsequent round of screening, whether it is among men or whether it is among women. So you can see that among men in the first round of screening, FIT is capable of detecting advanced adenoma between about 17% to 30% of the population. Of course, the detection rate increases with the age of the population. Similarly, for colorectal cancer, also we can see the FIT can detect a larger number of cancers as compared to GFOBT, and screen positivity of FIT is of course higher than GFOBT. The next slide, please. This is a graph which is showing the detection rate of advanced adenomas and colorectal cancers in the programs that are using endoscopy. Say, for example, on the left-hand side, you can very well appreciate that the detection rate of advanced adenomas is far higher with the endoscopy-based screening as compared to FIT-based screening. But the detection rate of colorectal cancer is not much different across the programs that are using endoscopy-based screening compared to the programs using FIT-based screening. Next one, please. This is something we need to really focus on. What is the participation rates in the colorectal cancer screening in different programs? And I'm just giving you some examples just to show how the participation rate varies between FIT-based screening and endoscopy-based screening, whether there is a variability across the sexes. So participation rate is defined as the proportion of eligible individuals who undergo tests out of those invited to screening. So these are all population-based screening. As you can see that excepting Netherlands, all the other programs are having participation rate below 60% in the feet-based screening, and in the endoscopy-based screening, both in Italy and Poland, the participation rate is still quite low. Next one, please. And in this backdrop, we are now facing the worst public health crisis in our generation, and it is bound to affect colorectal cancer screening as it is affecting all other screening programs and many other preventive public health programs. Next one, please. Just to give you an interesting example, Australia is one of the first countries that have come out with the study that has looked at the impact of COVID crisis on cancer screening program. On the left-hand side, you are seeing the impact of the COVID pandemic-induced restrictions and lockdown on mammography screening. You can see as compared to the weekly average rate of screening being done in 2018 during the peak outbreak of COVID in 2020, mammography screening was reduced by more than 90% in Australia. And after the lockdown was withdrawn, it is recovering, but it is at a much slower pace. On the right-hand side, what you can see is the impact of the outbreak on colorectal cancer screening. What is very interesting is that in Australia, the colorectal cancer screening is based on FIT, and the FIT kits are mailed to the eligible individuals, and eligible individuals can return the samples either by post or drop them at some collection points. So there is less of interaction between providers and the clients. And as a result, you can see that the impact of COVID is not that much on colorectal cancer screening. And immediately after the peak outbreak, it has very quickly gone back to the previous rates of screening. This is something to be pondered about, a point to be thought of when we think of post-COVID situation. Next slide, please. But then there are other possibilities as well. You know, the big advantage of endoscopy-based screening over FIT-based screening is that we can increase the interval between screening. Even we can think of a once in a lifetime screening. So that will further reduce the interaction between the provider and then the clients. Here, what you are looking at is the long-term risk of colorectal cancer and colorectal cancer deaths in men and women who are negative on colonoscopy. So as compared to men and women who are negative on colonoscopy, as compared to the men and women who have not undergone screening, the men and women who are negative on a single colonoscopy screening, they have 40 to 50% less incidence of colorectal cancer, which remains there even 10 years beyond the screening. And most importantly, there is nearly 90% reduction in mortality, which again remains sustained for many, many years, 10 years and longer. So we can safely go for once in a lifetime screening or increase the screening interval to 10 years. Next slide, please. Next slide, please. Yeah. And the same thing we are now seeing with flexible sigmoidoscopy-based screening. Again, there is a substantial reduction in incidence and mortality, which remains even beyond 15 years of a single round of screening. So these are the things that the countries need to consider in the post-COVID situation, with the full understanding of the challenges of and the resource requirement of having endoscopy-based screening. This requires discussion and then a concerted decision making in terms of changing in the colorectal cancer screening protocol. Next slide, please. I started with a happy note, but then I am ending with a little worrying note. And that is that we are seeing an increase in annual percentage of, an increase in incidence of colorectal cancer in younger population. As you can see, in many of the countries, we are seeing an annual percentage change of 4 to 6% every year among the younger population. And this is the age, as you know, is not the right age for colorectal cancer screening. Next slide, please. Probably parallel to secondary prevention, which is screening, we need to also think about primary prevention, which is essentially lifestyle modification with better dietary practices and more physical activities and less sedentary lifestyle. Thank you very much.